Osteoporosis. Definition: WHO defined a reduction in the bone mass per unit volume, or bone mineral density, deterioration in microarchitecture which results in increased susceptibility to fragility fractures, measured by BMD of individual and comparing it with a 30 years old, which assumes to be have peak bone mass, measured with T-score, which is sex and race match, or a Z-score, which is age, sex, and race match. T-score is best for osteoporosis. Z-score is best for metabolic bone diseases or osteomalacia. T-score of -1, this means standard deviation below the peak bone mass, classified as normal. -1 to -2.5, osteopenia. More than -2.5, less than -2.5, osteoporosis. Less than -2.5 with a fracture, severe osteoporosis. When you compare the male and the female, the bone mass density reduction is steady in the male, while there is a large dip in females after menopause. Females always have low BMD at all times. Risk factor: genetics, Northern European, Polynesian and African, low body weight, BMI of less than 19, environmental factors like Cushing, exogenous steroids, alcohol, smoker. How to measure BMD? You can do a DEXA scan, dual energy X-ray absorptiometry, or a quantitative CT. Only 18% who have positive DEXA scan will have fragility fractures. Whom do we scan? Postmenopausal female, more than 65 years of age, male of more than 75 years of age, any at-risk group like for develop a fracture, early menopause, Cushing syndrome, exogenous steroids, or alcoholics. Now we do something FRAX tool, fracture risk assessment tool, which has multiple factors: environmental factor, genetic factor, family history, and they divide into 3 groups: at risk, which need treatment; no risk, which doesn't need any treatment; and the middle group, which goes on to do a DEXA scan. Treatment is done on the basis of the results. NICE guideline states, number 1, everybody gets lifestyle modification and protection and avoiding alcohol and smoking. Number 2, vitamin D and calcium in diet, exogenous vitamin D and calcium supplementation. Interestingly, this does not affect the disorder of mineralization, so it doesn't reduce the risk. Then comes the bisphosphonates. There are 2 types of bisphosphonates: non-nitrogenous bisphosphonates. This produces toxic ATP analog and causes apoptosis of the osteoclasts. Then is the nitrogenous type, which inhibit the formation of brush borders by the farnesyl pyrophosphate pathway, and the process is called prenylation and acts on myelinolate pathway and stops the osteoclastic activity. The problems with bisphosphonates is osteonecrosis, with old bisphosphonates, especially jaw, fractures because it makes the bone brittle. That's why it's advisable to stop 3 to 5 years after that and do bisphosphonates holidays, and a risk of osteosarcoma. These factors, as described above, dietary modification, calcium, vitamin D, and bisphosphonates are the first line of therapy. Then comes the second line of therapy. Then you can give denosumab, which inhibit action of rank L and prevent osteoclast activation. Teriparatide, which is a recombinant PTH. It has PTH can cause osteoclastic resorption. Continuous use, but in pulsatile use, it will improve the new bone formation. Both drugs have short high half-life and bone mass rapidly reduces, so recommended with bisphosphonates known as a sealing the bone effect. Raloxifene, which is a selective estrogen receptor modulator, increased protective effect of estrogen is noted. This can be given in menopause, early menopause. Calcitonin, not recommended by NICE guidelines. And the third line of management is strontium, which reduces osteoclast activity, increase osteoblast activity, but there is a high number of cardiac side effects, so withdrawn.